Welcome, everyone, to the Cummings Graduate Institute podcast, Disruptors at Work, and Integrated Care podcast. CGI is a private accredited nonprofit university that offers the Doctor of Behavioral Health program in a 100% online format. CGI is focused on moving the needle of integration forward through advanced research, education, and training, including continuing education and workforce development initiatives. Our vision is to improve the way the world experiences healthcare. Today's episode is an update from Dr. Larry Ford on the process of reverse integration and creating from a behavioral health carve-out company, which was integrating through collaboration with providers. Dr. Ford today will talk a little bit of about the process of creating a primary care behavioral health medical home. So Dr. Ford is a doctor of behavioral health who founded Hands to Guide You as he fulfilled his doctoral studies. And he centers his practice on the certainty that there is no physical health without mental health. He has advanced Hands to Guide You as a preeminent leader in integrated care and population health in the state of Oklahoma and in the city, Oklahoma City. Dr. Ford's experience in the impact of chronic diseases such as COPD, depression, and anxiety on physical health have been peer-reviewed in articles in October 2015. So we're here today to talk with Dr. Ford a little bit about an exciting new update in his evolution of Hands to Guide You. And I'd like to invite you, Dr. Ford, to talk a little bit about the newest news in Hands to Guide You.
Thank you. So the newest news is, as you were saying earlier, that we are now a patient-centered medical home, which is extremely huge, not only in the state of Oklahoma, but as nationwide news. So now, as you said, we went from a behavioral health organization, carved out behavioral health organization, to now being able to provide primary care and manage patients. Mm-hmm. On the other side of that, now, as we've talked before about our state recently, we voted last year on the ability to provide Medicaid expansion.
Right.
We passed that goes into effect July 1, 2021. So what does that necessarily mean? That means that now no longer will we be our state will be managing behavioral health totally different. How's that different? Because before, as you know, there's two really pots of money when you're talking about healthcare. There's the physical health and then there's behavioral health.
Right.
Well, in physical health, many years ago, for many years, and even in other states, they've done what's called managed care, to where now managed care is totally different from a fee-for-service program. Managed care is about managing cost, utilization, and quality of care, and focusing on outcomes, right? That's totally different from fee-for-service. Fee-for-service is you provide a service and you get paid a fee for that. Mm-hmm. It's not so much focused on outcomes, quality, or assurance, right? So now the state of Oklahoma is going to be getting into managed care on the behavioral health side. So it changes the dynamics of behavioral health in the state of Oklahoma.
Yeah.
And we are negotiating with insurance providers already throughout the state to become a leader in the managed care industry from the behavioral health side. And we want to take it a step further and be a leader in the state for managing care for the population, period. So mm-hmm. Meaning not just behavioral health of the primary care side, we want to be a leader in managed care, period, in the state of Oklahoma.
Mm-hmm. This is so exciting to me in a lot of different ways. And as you and I were kind of talking about before we started our podcast today, you and I both went through the program that Dr. Nicholas Cummings founded, the Doctor of Behavioral Health program.
Yeah.
And, you know, one of the quotes that you mentioned from Nick Cummings is, healthcare will change when doctors of behavioral health become the CEOs.
Yeah.
Something that you and I use as a guiding principle. Can you talk a little bit more about how you see your role as chief executive making the difference that perhaps, you know, a person who is primarily in only a clinical role can make?
Mm-hmm. Yeah, so nearly a decade ago when I started the organization, I was started the organization with the mindset of being the chief clinical officer. Now, a decade later, I'm truly a chief executive officer. So my thoughts and my decisions and the structure of the business is totally different. You know, a decade ago, we started Hands to Guide You Behavioral Health. Now, a decade later, and this is ultimately breaking news, I'm starting H2GY Health, the better healthcare experience focus. And now we have two subspecialties, behavioral health and primary care. So the structure of the business is completely different, going through a rebranding, negotiating contracts with insurance providers, and just really ultimately focus on the patient and giving the patient the best healthcare experience possible.
Mm-hmm. And I think one of the things that excites me about your breaking news today is the idea that a DBH, a person, you know, with primarily clinical training and advanced training in both behavioral health and integrated care, is leading the structure of healthcare as the state of Oklahoma moves forward. Because, you know, before I started meeting with you today, I was part of a group with the International Foundation of Integrated Care.
Mm-hmm.
They have a huge annual conference every year. As you know, you went to one in Dublin, Ireland a few years back. And you know that colleagues from all across the globe are coming like bees to a beehive to discuss. You know, I think we called it the Cathedral of Integrated Care. Those are our people. And it's so exciting to be part of a community like that, because across the globe, many countries with national healthcare are structuring healthcare based on principles of quality and effectiveness and efficiency. And we really differ here in the United States from the perspective of this being a non-national healthcare nation. And it is up to us. We have learned over time, as we've tried to innovate, as we've tried to implement innovations, that a lot of this is truly up to us, because the system doesn't always support integration and it doesn't always support innovation. And so it's exciting to me to hear the work that you're doing in Oklahoma, because I really feel like it's shining a spotlight on the possibilities for doctors of behavioral health, but also for healthcare providers in general. If not us, then who? And if not now, then when?
Yes, exactly. In fact, the healthcare system is set up opposite. It's not for integration or working together, the collaborative approach. So being able to have the knowledge to do what it takes, and then having the ability and the confidence to continue to be innovative and create something that doesn't exist is truly amazing from my standpoint.
Yeah. I love that statement, creating something that doesn't exist, because it is truly patient driven. It is patient centered. It is patient focused. We are fine-tuned focused on the patient experience and their right to have the best healthcare possible, and our passion about finding a way to deliver that best care possible.
Yes.
Instead of just, you know, looking to the system, blaming the insurance industry. How can we be part of the solution? How can we partner with the industry? How can we partner with the system?
Yes, exactly.
So earlier, before we started recording, we also were talking a little bit about one of the barriers that many people often ask, or one of the frequently asked questions when they are considering entering the Doctor of Behavioral Health, the DBH program, which is, if there's no license for a Doctor of Behavioral Health, then what is the value of the degree? And I know you have some pretty strong feelings about that.
Oh yeah, and that obviously started from Dr. Nick many years ago, and but you know, we entered the program as clinicians, you know, and we're still clinicians, ultimately still expert clinicians, but we entered the program with a different mindset, and we truly left the program with a different mindset. And it's no different than a PA or a nurse practitioner or anybody else, or a nurse or a physical therapist entering a medical program, a doctoral program, where you leave with a truly different mindset. And it was no different from us. We came in as clinicians and we left with a totally different mindset. You also, we came in as clinicians and we left as executives. And really 10 years ago, a decade ago, I didn't realize I knew the executive knowledge that I have, but now I'm still to this day putting the executive mindset into place. And it's having the ability to execute executive contracts and being at the executive level in every conversation that I have with major organizations in the hospital world and on the insurance world. And what's best, I believe now, what's best about it is the ability to have these executive meetings with the insurance providers and talk about improving the care of their population, because they truly have the hub of healthcare, because they have the patients, they have the population, and being able to talk with them about improving their population and decreasing cost and improving cost of care and improving outcomes is truly phenomenal and amazing to have the ability to do.
Yeah, I completely agree. And I love, one of the other things that you said earlier that I loved was you mentioned how sometimes as kids, when we're, 14, 15 years old, our parents are telling us, important things, life lessons that they've learned, but it takes until we're maybe, 30, 35 years old, 40, 45 years old to look back and go, I get it now.
Yeah.
And, like you shared before, I think until we're doing the kind of executive work that you're describing, we don't necessarily entirely understand all of the wealth of knowledge and the value of what was distilled in us from Dr. Nick Cummings.
Yes.
Until we're in those same shoes that he was in, executive, negotiating contracts with the health system, advocating at the state level or the national level or the international level for what patients need and our power to enact that change, to implement those changes, because we know the science.
Yes. And I remember you just made me remember something. You'll remember this because he said it all the time. When he was transitioning and going to those next steps and those next levels, he always talked about how he still practiced at least 2 days a week, every week. He would still practice 2 days to keep his clinical skills and knowledge up to par. And those other days he was focused on the executive duties. And now, it's surreal and it's exciting also to be transitioning to those steps and to have to make those steps and follow the model still to this day.
Yeah. And that's such a great point, because that's a model that I've been following. When I started the DBH program, I was in a transition between one clinical role and the next. And I was able to start, a part-time clinical role as a DBH student. And I've continued that role to this day. And I just recently I like to call it evolving, right? I just evolved, from the day-to-day, clinical services to really at the state level, being able to share clinical expertise as part of a really important data review committee. I'm now sitting with the Maternal Mortality Review Committee at the state level for Arizona Department of Health Services. And I'm also on the Maternal Health Task Force for the state of Arizona. And I don't think that is something that we necessarily recognize as part of the huge value and opportunity inherent in being a doctor of behavioral health. But I absolutely believe, having worked with lots of international colleagues, that the way forward is through policy enablement. Because as you and I both know, especially here without national health care, there are so many barriers, legislative, state barriers, national barriers. One great example is the mobility of a person with a clinical license to be able to go from one part of the country to another in the event of a crisis, in the event of just a family move, and be able to hit the ground running as a solid, advanced, high quality level health provider. And so there are so many things that we have to work on, and we have to begin to see our opportunity as executives, as state and national leaders and international leaders in healthcare. But I always like to say that, I chair the culminating projects at CGI. And I think one of the big things we talk about a lot is all the opportunity. And for a student, that feels like a lot of pressure.
Yes.
I am one person against the world. And so I like to, you know, I really liked what you said about, you know, it may take a few years for us to really fully understand the lessons of our, you know, leaders, those who've been going and doing this before us, and that it's okay. And that it is an unfolding, evolving, you know, view of opportunity for yourself as a DBH. Excuse me. And I think that is so important, because the more you allow your passion and, you know, your critical thinking skills to guide you in the direction of opportunities you've identified, those gaps in care that you've identified, and to get out there and address them and fill those needs.
Yes, and this was a perfect time, because I agree exactly with everything you were saying. And with this pandemic, with COVID-19, you know, there's a lot of red tape in our country, and now we're realizing it more and more with each day that passes, even currently as we speak with the pandemic with COVID-19, because we've gotten calls from Texas, from Florida, from New York, from Arizona, from California, of patients just reaching and trying to find anybody that can help them through their current struggles and their situation, and not being able to help everybody in real time adds an amount of frustration and amount of critical thinking of what can we do to help, and how can we help, and what do the laws say, what do the practicing laws say, and how can we be more transparent and have better access to care for people, not just that live in the state of Oklahoma, but people, how can we improve care and improve access to care for patients in Texas? If we can get them in, and it shouldn't really matter if you live in the state of Texas or if you live in the state of California or Florida or wherever you live, if you have the opportunity to see a provider and get better help and get treatment now, what's the holdup? What's stopping you? So, you know, it's a lot of things we have to do.
Yeah, and it's complicated. It's not simple. It's not, I don't think there's ever been a single time where healthcare has been clear and simple. So I think we have to be prepared as doctors of behavioral health to deal with uncertainty and complexity and have a lot of patience. There have been times where I've become very impatient at the time that it takes. You know, for a committee may gather data for 3 years, 4 years before it ever takes any action. And that was one of my questions to the State Department, you know, well, what is the purpose? You know, because if I'm going to volunteer my time, I don't have a whole lot of free time available. So if I'm going to volunteer my time, I need to know how my time will be used, and, you know, to what degree I can make an impact. And, you know, so I think it's fair to say that sometimes as doctors of behavioral health and as executives, we get impatient, and that's normal. But we also need to learn to have a sense of patience for the process of change, because change takes time, and there are a lot of people who do not get it right away, but after working with us over time, they begin to see things differently. They begin to see through, you know, forest for the trees. They begin to see the bigger picture.
Yeah, exactly.
It's really exciting.
Yeah, it is.
So tell me a little bit about how are you specifically approaching right now the Medicaid, Medicare negotiation process? What does that look like?
Well, we're still on the early end, but the good thing for us, at least so far, is they've been reaching out for us just because of the work we've been doing in the behavioral health industry, and some of the results and as it relates to outcomes and quality of care that we've been already doing. So there's several insurance organizations that have been reaching out to us wanting to know if we're even interested in the managed care process. And, you know, after talking to them and them seeing the knowledge that I already have in managed care, and the knowledge and the excitement that I already bring, it's been going very well. So it's just going to be like renegotiating contracts and going from there.
Yeah, I love that. And one of the things too that you were mentioning earlier, I think this is something that people fear when they don't have the confidence that they can make a difference. Your patient population on average tends to have an ACE score of between 7 and 8.
Yes, which is very high. So we have a very high acuity of patient that we see on a routine basis. And for me, clinically and executively, it's extremely exciting. I mean, to the point to where words can't even always describe it, but it's so exciting to be able to truly offer a service that isn't being matched, so to speak, in the era that we live in, being able to provide a more holistic care approach, a decade ago, starting and then being here to where we're actually having to rebrand because we're doing something totally different is amazing and exciting.
Yeah, it really is. It really is. And I think, just being able to tackle a population that has the highest level of complexity and acuity is is really something that Nick Cummings envisioned for all of us as doctors of behavioral health. He often said that, as a surgeon, you can't be squeamish or fear the sight of blood.
Yeah.
His vision for us was to not be afraid of the psychic blood, the impact of trauma that we see in the population, and to know and have the confidence that we are the people that these patients have needed throughout their healthcare experience, throughout their lifespan, and that we can make a difference if we're willing to address that complexity and do what needs to be done, work as a team, communicate and collaborate like a team, like the patient needs and deserves. And you and I probably have a million examples of patients whose treatment suddenly accelerated when they started to interact with us as a doctor of behavioral health, simply because of our knowledge about self-advocacy as a patient, and the willingness and action taking on our part of communication and collaboration with their other clinicians, their medical team.
Yes, definitely. Because, as we know, healthcare is so much more than just coming to our office or coming to our practice and treating them and getting them better. Now we understand that healthcare, getting into population health, but healthcare is so much more than what providers all around the country understand. Getting into the coordination of care and the social determinants of health, and finding out what all do they need and why are they not complying with their medication. Where do they live? What access to do they have in the communities that they live in? Because all of those factors impacts their health. So being able to get them on a healthier diet, being able to make sure that they have access to their pharmacies, being able to make sure that we're all working together, all of the providers are on the same page, and having care managers work with the patients so they can help the patients with follow-up, advocating for the patients, monitoring some of the things that we work on here in the office. It's just an extension of ourselves and in our office, and that's very rewarding to see somebody come into your office in the state that they come in, and months later or sometimes days later or weeks later to see the results of working together and being on the same page, because they're truly putting the patient in the middle and have in the middle of their care, and running and guiding their care, and really taking over their own health. And it's very rewarding to see.
Yes.
Because the beginning never looks like the end. The beginning of treatment never looks like the end of treatment.
That's absolutely true. And I think the big takeaway for me from the program as a clinician was that shift from measuring productivity in terms of the number of people that were being served to the outcomes.
Yes.
Measuring the outcomes, reporting on the outcomes, and reporting those outcomes to the patient, so that the patient understands what to expect and how to measure their own level of engagement with their healthcare team, and then to take advocacy and sovereignty of their own health if they feel they're not getting the outcomes they need.
Yes.
Exactly. I think a lot of patients are not, for example, the last time I went to my primary care doctor with a question, I might have walked away with 2 or 3 prescriptions and no answers. And so, I think that the value of us working to help them lead their own healthcare team helps them start to ask, well, what are the outcomes that I can expect? And when can I expect to see those outcomes?
Yeah. And as a whole, just from practicing for over the last 10 years, seeing, you know, when we were in school and going over some of the things, and we first heard that for the first time, you know, being trained on um, medication shouldn't be used as the first line of defense. And nearly a decade later, and seeing the thousands of patients that not necessarily want medication as a first line of defense, but want, you know, better outcomes, and what can they do to improve their health outside of the medications, is a total different approach, but it's very rewarding to see patients when we are treating them and not using medication as the first line of defense, and helping them, really giving them the tools that they need to improve their own health on their own, is so rewarding. And then on the other end, patients coming in on between 15 and 25 different medications, and then through successful treatment and coordination of care, and managing their health so much better, from them going from 25 medications to maybe 15 or 10, or being on very few medications once they're successful in treatment, is very rewarding. And just to see where they are and where they stand is so much better.
Yeah, absolutely. Before I started the Doctor of Behavioral Health program, Larry, I had my aunt was, you know, she had a chronic history of type 2 diabetes and cardiovascular disease. And she had had a couple of heart attacks. And she called me one day, and this is, you know, long before I started my Doctor of Behavioral Health journey. But even as a master's level clinician in behavioral health, when she told me this, I was shocked, and I knew there was a massive issue in her healthcare. She told me she was on 40 different kinds of medication. She said, I can't even keep up with what all I'm supposed to take on a daily basis. I don't know what I'm not supposed to take anymore. No one was sitting down with her and saying, like Dr. Janet Cummings teaches us, bring me every medication and every over-the-counter medication in your cabinet, and we are going to go through it all together.
Yes.
And I think that was one of an early, you know, just bits of excitement for me as a DBH student, learning that, you know, that was a strategy we could and should be doing for
Yes,
patients.
100% of the time. Yes, I agree. Yeah, and this, you know, it's a very different approach, but you know, the patients want it, and the patients want more control of their own health, because at the end it's their health. So why
Yeah.
not put the patient in charge of their health, but give them the tools to manage their health better and treat their health better, and show them what it takes to improve their health. You know?
Absolutely. And it's a really exciting thing to start using the word sovereignty with patients when it comes to health, because I don't think a lot of people have grown up with that idea that you are actually sovereign over your body.
Yes.
You control your body, and what you put in it makes a difference. And,
Yes.
you know, what you are directed to do by a clinician makes a difference.
Yes.
And you have a choice. You know, I always talk about that with patients who are wondering if a psychiatric medication would be a good fit for them. I always say, you are sovereign over your body. You have an autonomous human body, and I encourage you to, you know, review the information I'm going to give you and that we're going to talk about, and think about what's best and what's right for you, and what reflects the decision that ultimately reflects what you feel is right and best for you.
Yes.
And, you know, then I say, I'm going to let you walk away. You don't have it unless you want a prescription. Walking out the door today, we'll make that happen for you if that's your preference, but you do not have to accept a prescription today. And if
Yes.
anyone on the team tells you you must take this prescription, I'm always available to talk to you about it. And the team will sit and talk to you about it. It's not a do this or else you can't be a patient here with me.
There you go.
Mm-hmm. So, well, thank you so much. I want to be respectful of our time. Are there any last thoughts that you'd like to share, or any other exciting news that you want to ask the audience to kind of watch this space for?
No, I just say stay tuned. We're continuing to grow and continue to improve access to care and be readily available for the community. And we're continue to come to work every day to figure out more ways to improve the way the world experiences healthcare.
So exciting. Thank you so much for your passion and your leadership, and for the example that you're setting for so many of us. I really appreciate you, and I'm just such a huge fan and a big supporter of your work. And I love being a colleague with you. I think that's one of our benefits to one another, is that we inspire each other, and, we're able to help keep each other encouraged and looking forward.
Yes, yes, I agree. For many years, we couldn't even imagine nearly, well, a decade ago. It doesn't even seem like that much time has passed from being in school and class together to now being executives and leaders in the country in healthcare.
Yeah, it's really exciting. I think back about the first time I sat in, DBH conference, and you sat behind me, and we started our conversation then, and we've been having that conversation has never ended, and I'm really grateful for it. All right, Dr. Ford, thank you so much. You have a wonderful day, and I can't wait to bring you back soon for another update.
All right, thank you so much. Talk to you soon.
Yes, thank you.
All right.